So this is our final case study. It is on the therapeutic management of COVID-19. A 61-year-old man with a history of rheumatoid arthritis, hypertension, hyperlipidemia, and depression feels unwell with symptoms of fever, dry cough, and sore throat. His PCR COVID-19 test results returned positive today. These are his medications he's currently taking: methotrexate, adalimumab, amlodipine, rosuvastatin. The patient called immediately his pharmacist and asked how he can receive treatment. He does not require any supplemental oxygen at the present time. Does this patient qualify to receive Paxlovid? In presenting this case study, briefly discuss the mechanism of Paxlovid in the treatment of COVID-19 infection, provide evidence of Paxlovid's efficacy and safety for treating COVID-19 infections, and finally, how or if you would need to adjust the doses of his current medications. So Paxlovid is the brand name for an investigational SARS-CoV-2 protease inhibitor antiviral therapy that is developed by Pfizer, which is made up of two generic medications, nirmatrelvir and ritonavir. The recommended dosage is 300 milligrams of nirmatrelvir, 250 milligram tablets with 100 milligram ritonavir, 100 milligram tablet, all taken together orally every 12 hours for 5 days. The FDA approved nirmatrelvir and ritonavir in December 2021 to be used for non-severe COVID-19 cases, but that cases in risk of progressing into severe disease. So going back to our case study, the patient is aged more than 60 years, has a history of hypertension, which is a major risk factor for increased severity and mortality associated with COVID-19. His COVID-19 symptoms are currently mild to moderate, therefore he's a good candidate for Paxlovid. So first, let's look at nirmatrelvir and its mechanism of action. Cysteine proteases, amyl-Pro and M-Pro, are needed for the cleavage and maturation of proteins to make them functional for the viral replication process. Therefore, these proteases are good targets for an antiviral medication against COVID-19. Nirmatrelvir binds from its nitrile site to the catalytic dyad of cis-145 and his-41 of M-Pro. You can see here, and it inhibits the M-Pro proteolytic activity in all 7 types of human coronavirus. So antiviral protease inhibitors may be relatively safe drugs in humans because mammalian protease enzymes have different substrate specificity. At the highest tested dose of nirmatrelvir, there were no inhibitory activity observed against several mammalian proteases, such as aspartyl, serine, and cysteine proteases, as well as HIV proteases. So ritonavir is a tripeptide structure which inhibits HIV protease by binding to its functional site, and was originally approved in 1996 for HIV treatments. Ritonavir affects drug metabolizing enzymes and transporters. It is an irreversible potent CYP3A4 inhibitor, reaching maximal inhibition effect at a dose of 100 milligrams, and therefore can substantially increase the plasma concentrations of concurrent drugs that is predominantly metabolized by CYP3A4, such as nirmatrelvir. In addition to CYP3A4, ritonavir inhibits P-glycoprotein, breast cancer resistance protein, organic anion transporting protein polypeptides, 1B1 and 1B3. Ritonavir also induces CYP1A2, CYP2B6, CYP2C9, CYP2C19, as well as the UDP glycuronyl transferase. In terms of the safety and efficacy of Paxlovid, several meta-analyses have shown that treatment with Paxlovid is associated with a significantly lower mortality rate in COVID-19 patients compared to control. A significantly lower rate of hospitalization or death in COVID-19 patients treated with Paxlovid was compared with those receiving placebo, another antiviral, and those with no specific COVID-19 treatment. And there are no significant differences between the two treatment groups in terms of incidence of any adverse effects in patients. So drugs predominantly metabolized by CYP3A4 are expected to be profoundly impacted by ritonavir as the major metabolic pathway is inhibited. CYP3A4 mediates the metabolism of amlodipine, used to treat high blood pressure and coronary artery disease. And this is taken by our patients in the case study. Amlodipine AUC increased twofold when co-administered with combination medications with ritonavir. So based on the University of Waterloo University of Toronto drug interaction guide, it is recommended to reduce amlodipine dose by 50% or take dose every other day. Restart usual dose 2 days after completing nirmatrelvir and ritonavir. Also, blood pressure should be monitored, and you may consider continuing the usual dose in patients at low risk of bradycardia or hypotension. Another medication that the patient was on, rosuvastatin, is known as a substrate of organic anion transporting polypeptide 1B, which is an inhibitor of ritonavir, which is inhibited by ritonavir. Rosuvastatin AUC increased twofold, and Cmax increased almost fivefold when co-administered with a ritonavir combination medication that was taken twice daily. And so based on the University of Waterloo, University of Toronto drug interaction guide, it recommended that the rosuvastatin should be held and restarted 2 days after completing nirmatrelvir and ritonavir. Alternatively, you can reduce the dose of rosuvastatin to 10 milligrams daily and resume usual dosage 2 days after completing the ritonavir nirmatrelvir trial. So going back to our case study, we would recommend that while on Paxlovid, based on current recommendations, dosage of amlodipine can be decreased by 50% with close monitoring of blood pressure, and dosage of rosuvastatin can be reduced to 10 milligrams daily, and both medications can be restarted on the original dose 2 days after completing Paxlovid. Methotrexate and adalimumab can be continued as usual over the duration of the treatments because they are not affected by Paxlovid. So this is the end of the case studies for COVID-19. Remember to take the quiz 3 that is posted on Quarkus at 1 p.m. today, and that will be part of your participation grades. So don't forget to complete the quiz. Thanks, everyone.